Well, thank you all so much. I'd like to begin with some quick thank yous. First to Dr. Zhao, thank you so much for being here this morning and for introducing this workshop. Thanks to the leadership team of the Roundtable for supporting our conducting a workshop on this topic, Bill Purcell, Mary Story, Bill Dietz, and Lynn Parker. Thanks to the planning committee that helped put this wonderful program together. Most of them will be directly involved in moderating program sessions over the next couple of days. We've attracted, I think, a remarkable group of speakers to the workshop, and I appreciate all of them finding time to be here because the timeline for planning the workshop was demanding. We've had remarkable staff support for this, for preparations for this workshop, and Dr. Zhao mentioned them, but I'll mention again Heather Cook, Sarah Siegel, Sarah Ziegenhorn, who've been tremendously engaged in putting this together, and thank you to the audience. Wouldn't make much sense for us to be here if you weren't, so thank you all very much for being here this morning. I'm going to do three things as quickly as I can. First, I think my primary job this morning is to set the stage, to establish a context for the sessions that will take place today and tomorrow. And my operating assumption, and I think our planning committee agreed that this was probably the case, and that is that many who will consume this workshop will not be intimately familiar with physical activity science. And so part of what I'm going to do is provide a quick history of what we've learned over, I think, quite a long period of time about the health implications of physical activity. I will then do a little primer on how at least some of the factors that have been applied when research has been undertaken on the physical activity health relationship, and then provide some brief introductory comments about the workshop. So a quick history. The idea that physical activity is important to health is not new. The ancient scholars and physicians believed it, wrote about it. Hippocrates said walking is man's best medicine. So probably intuitively, great leaders throughout history have seemed to understand that physical activity was important to health. But it really wasn't until the 20th century that what we would call science began to be applied to physical activity and exercise. And the field of exercise physiology actually got off to a fast start. August Krogh, a Dane, was one of the early exercise physiologists and a Nobel Prize winner in 1920. He was followed only 2 years later by A.V. Hill, a Brit who did remarkable research really on the energetics of muscle function during exercise, and he too was a Nobel Prize winner. We haven't had one since. We're overdue, I think. In the U.S., an entity called the Harvard Fatigue Lab was active for 20 years, just up to the end of the World War II era, and trained a lot of people, spawned a lot of exercise scientists who sort of migrated out around the country and populated academic programs around the U.S. Really to today. And at that time, most of the science on physical activity and exercise was physiologic in nature, focused on understanding the basic physiologic responses to exercise. In the middle of the 20th century, some very prestigious epidemiologists got interested in the health implications of physical activity, and I think you could probably argue that we're here this morning in no small way because of the work of Jeremy Morris in the U.S. and Ralph Paffenbarger in the U.S., who were very well-known and highly regarded epidemiologists before they got interested in physical activity, and I think we benefited tremendously from really the credibility that they brought to their work. Jerry Morris, of course, in the early 50s published work comparing health outcomes in the more sedentary conductors that worked on or more active conductors that worked on the double-decker buses in London as compared with the sedentary drivers. In this country, Ralph Paffenbarger continued that work with a range of occupational groups, including longshoremen on the West Coast and the Harvard alumni from Harvard College. Paffenbarger produced what some of us refer to as the Paffenbarger curve. This relationship between physical activity, heart disease outcomes, and now, several decades later, a wide range of other chronic disease outcomes really has been replicated over and over again. And I think the basic message is you don't want to be sedentary. The low end of that activity continuum is associated with substantially elevated risk, in this case, of fatal and non-fatal heart attacks. But as we know, you can almost fill in the blank with many other chronic disease outcomes. Very similar patterns have now been demonstrated. And fitness, sometimes used as a surrogate measure of physical activity and sometimes as a critical important construct itself, has also been shown to be related to the same constellation of chronic disease outcomes. And Steve Blair and others' extensive work in the aerobic center longitudinal study have demonstrated repeatedly that avoidance of, in this case, the low fit quintile would be a very important public health advance. I think by the early 90s, the evidence supporting the important health implications of physical activity reached sort of a critical point, and then the American Heart Association issued what I think in retrospect was a seminal statement on exercise, acknowledging that inactivity or low physical activity should be recognized as a risk factor for coronary heart disease. I think that formal statement by a very authoritative organization opened the floodgate. Just a few years later, the first public health statement on physical activity was produced as a collaboration between the CDC and the American College of Sports Medicine, basically recommending that all adults should accumulate 30 minutes or more of at least moderate intensity physical activity. That was followed quickly by the production of the first and still only Surgeon General's report on physical activity and health, which essentially endorsed the same recommendation. The science continued to accumulate. I don't know that it was cause and effect, but at least concurrent with the release of some of these authoritative documents, just the raw volume of research on physical activity, exercise, and health took off, and it continues to take off. That last bar may look like it's plateauing, but 2015 is not over yet, and I think by the time the year is over and we can fully account for all the publications on that topic, I think we'll see it's a sort of a continued curvilinear increase in the, just the raw volume of research on physical activity and health. Fast forward now to just a few years ago when the federal government for the first time issued fully approved physical activity guidelines. The advisory committee that informed that report did a very extensive review of the literature, and I'm going to quickly summarize the conclusions here, but there was strong evidence for quite a broad constellation of important chronic disease health benefits associated with higher levels of physical activity. And I highlight prevention of weight gain as one that was on that list here for adults. Obviously, in the context of this workshop, that is highly relevant. For older adults, the same list applied, but in addition, included better functional health in the elderly, clearly a critical outcome, but also reduced abdominal obesity, relevant to the topic here. And then for kids, strong evidence of, again, a range of important health outcomes, but including more favorable body composition. So clearly, the Physical Activity Guidelines Advisory Committee report did conclude that there were very important benefits associated with avoidance of overweight and obesity across the age range of those considered for the report. That informed the guideline, which for adults is that essentially 2.5 hours per week of moderate intensity activity is recommended. That's not really different than the earlier recommendation of 30 minutes most days of the week. For kids, the recommendation is an hour a day. And what's it all add up to? Well, for one thing, since we know most Americans are not meeting those guidelines, I think we know that the risk attributable to failure to meet the physical activity guideline is tremendous. And there have been a number of these attributable risk analyses published that have included examination of the impact of physical activity. This happens to be just one of them. There are others, but if you look across them in the U.S., the estimates from these attributable risk analyses are somewhere between here 191,000 premature deaths to up to 300,000. So clearly, the impact of low levels of physical activity constitutes a very substantial public health problem. Just a couple of years ago in The Lancet, Diamond Lee and colleagues published what I consider to be a tour de force examination of the worldwide impact of low levels of physical activity, and concluded that for many of the important chronic disease outcomes, somewhere in the range of 7 or 8 to 10% across the world of those cases can be explained on the basis of physical inactivity. Remarkable conclusion. So where did this evidence come from? What are the kind of the guidelines and principles and premises that scientists have applied in studying physical activity? And what I'm going to do for the next 2 or 3 minutes here is overview a few of these concepts, and the reason for doing it is to hopefully support the efforts of the speakers that will follow here later today and tomorrow by laying out some basic terms and concepts so that they won't have to do it on a repeated basis. So in order to study a particular construct, you've got to define it, and physical activity has been defined as any bodily movement produced by skeletal muscles that results in energy expenditure. And I think it probably is relevant to point out that including the phrase energy expenditure in this definition is highly relevant. I think that sort of the energy throughput impact of physical activity is really a very fundamental underlying premise that is applied in this research. Physical activity is a complex behavior, and its attributes include the type of activity, the specific form of activity, the frequency with which it's performed, the intensity with which it's performed, the duration of bouts or the amount of activity performed per day, and the context, the physical location, the social setting. So there are many elements to the physical activity behavior that are relevant in studying its impact on health. Again, in order to study a particular construct, you've got to be able to measure it, and physical activity has been measured in many different ways, by self-report, by surrogate report, by parents and others around the target individual, by direct observation, and over the last 15 or so years by objective assessment via accelerometry, motion sensors, or pedometry. I guess I'll just editorialize briefly to say that I think the development of methods for objective assessment of physical activity has been an enormous advance in our ability to do science on physical activity and produce findings that are well regarded by the scientific community. Fitness is sometimes used as a surrogate indicator of physical activity, sometimes, of course, measured as a critical biomarker or physiologic indicator. Physical activity in the range of scientific studies has been expressed in a lot of different ways. Sometimes it's been expressed as a selected intensity of physical activity per unit of time, such as moderate to vigorous intensity physical activity expressed as minutes of that activity performed per day. Sometimes the overall dose of activity is used analytically. For example, the MET is a unit based on resting energy expenditure or multiples thereof, and So the product of intensity and duration produces a metric called MET minutes that is sometimes used as an expression of overall dose of activity, or activity can be expressed as compliance with a guideline. For example, the number of days per week on which a guideline has been met. Many different health outcomes, health indicators have been studied, they include the full range of biomarkers, blood lipids, blood pressure, insulin, and adiposity, fitness, disease morbidity and mortality, in particular cardiovascular disease, type 2 diabetes, obesity, and of course all-cause mortality. And I think it's probably true that that this field achieved a status that it hadn't had before when the large epidemiologic data sets matured to the point that all-cause mortality could be examined as a viable outcome associated with the range of activity levels. Why does physical activity exert this influence on health? Well, we certainly have a lot more to learn about this, but first I think it's important to appreciate that just the participation in exercise as an acute activity produces a very profound physiologic response. The average person can increase their metabolic rate during activity 5 to 10 times the resting level. Athletes 15 to 20 times the resting level. But if you take it down to the level of the skeletal muscle, that tissue can increase its rate of energy expenditure enormously. And that activity, that metabolic activity in the active muscle requires a tremendous physiologic response, and essentially all systems of the body are engaged in supporting the active muscle during activity, in particular the neuroendocrine control systems and the cardiorespiratory system. Regular participation in physical activity produces a broad range of adaptations, multiple effects on the muscle metabolic apparatus. The muscle gets better at performing activity, and in order to better support the muscle during activity, there are important adaptations in cardiorespiratory function, neuroendocrine control mechanisms, and the tissues change. The connective tissue, bone, adipose tissue all adapts to the increase in activity, and we have improved fitness, which is itself a very important indicator of health. Finally, there I think almost certainly some very basic factors that underlie the health effects of exercise, and a critical one may be increased insulin sensitivity, which clearly results from regular exercise. It results from an acute bout of exercise, but also would include lower visceral adiposity, improved immune function, increased blood volume and hemoglobin mass, improved cardiac structure and function, and many other underlying mechanisms that are yet to be confirmed, or for that matter determined, and some in the room know there's an ongoing effort to encourage the NIH to focus more funding on research that's aimed at better understanding these underlying mechanisms that mediate the effects of exercise on health outcomes. So one way to look at the issue of physical activity and health is sort of the reductionist approach, which I've just taken you through, right? It's sort of look in great detail at specific changes that occur with increased activity. But another way to look at it is just think logically about what's probably going on here. And I think a teleological analysis would be our bodies evolved to be what they are when we were hunter-gatherers. And consequently, our bodies evolved to support that lifestyle, which was a physically active one. And so I think one way I look at the issue is to say, well, if that's really the norm that our body evolved to support, and we're no longer living that way, or at least many of us are not, it shouldn't be that surprising that things don't always go well, that our body doesn't handle it well when we're living in a way that our body really did not evolve to support. So one way of thinking about it is the adaptations that we see to exercise training really are changes that reflect a reversion to the norm, not some odd, behavior pattern that only a bunch of Y-rats would really be interested in adopting, right? This is the way we were meant to live, and when we go back to living that way, good things happen. So we're here for a workshop that I think is a very important opportunity. On day one, we're going to be focusing on physical activity and obesity and focusing on the state of the science regarding that relationship. I will say that I think there's certainly much more that we need to learn about this, but I'm delighted that we have the opportunity to focus on what we do know, what we still need to know today. Tomorrow, the attention will shift to strategies for promoting physical activity. Today, the focus on physical activity will be on primary prevention of overweight and obesity. And in addition, there will be a focus on prevention of comorbidities in those who are already overweight or obese. And we'll begin with 2 introductory presentations, followed by 2 panels that will focus on primary prevention, and then a panel on health outcomes associated with increased physical activity in those who are already overweight. And with that, I'm delighted to introduce our 2 speakers who will be up next. First, our keynote today will be presented by Dr. James Hill. Jim is a professor of pediatrics and medicine at the University of Colorado, Denver, director of the Center for Human Nutrition, director of the Colorado Clinical Nutrition Research Unit, and executive director of the Anschutz Health and Wellness Center. And Jim has spent over 25 years researching the causes of weight gain, adiposity, and obesity, and how to prevent or treat these problems. He will be followed by Aviva Must, who will speak to us about physical activity disparities. And Aviva is Morton A. Madoff Professor of Public Health and Chair of the Department of Public Health and Community Medicine at the Tufts School of Medicine. Aviva is an epidemiologist who has worked in population-based obesity research since 1988. She focuses on the epidemiology of obesity across the lifespan, with a particular interest in physical and psychosocial health consequences during adolescence and in vulnerable populations. So please join me in welcoming Jim Hill to the stage. Thank you.